Thank you very much. I'm very pleased to be here. I've got no conflicting interests to declare at all. Now, the first thing to say is I work here most of my time at St Mary's in Paddington, and it's always interesting to see, because I was here when this photograph was taken, and it was pouring with rain, and somehow they managed to doctor it into a blue sky, which seems to always happen when we look at NHS hospitals. But the other place I spend a lot of my time is here at the training ground for Chelsea Football Club as well. And I think this is where it becomes very important around adolescence, because although we think of football teams and the sort of first team that being the pinnacle of everything, the majority of players within any academy or any football setup are actually the younger ones and the adolescents. And actually, they're an increasingly important part of development of sport within this country. If we look at the number of children who are entering into football, especially female people entering into football, it's at this age group that we need to catch them and bring them through the academy systems to really bring them out in terms of their sporting achievements. But back to the sort of main topic of what we're talking about today. So it was this chap, Rajeswaren, who first came up with this slogan that children are not young adults. And I sort of take that with a little pinch of salt. Although I'm a paediatrician, a paediatric A&E person by background, I do sometimes have to say that paediatricians over-egg that a little bit. But in MSK terms, it's absolutely true. And we're going to go through some of those differences between the adolescent, the children, and the young adults to see exactly where those differences lie. So the first one's around anatomy, and we know this, that the sort of shorter height, the head ratios all change as you go through life. And this really does produce different forces on the child in terms of biomechanics, but also the potential for injury of different areas as well. So we always got to think about that. And I suppose the biggest anatomical differences really come within the developing bone. So for in terms of the adolescent person, when the bone is forming in themselves, we've got higher water content. The bones are less brittle. They're much more likely to flex and to bend. They're more porous. They've got wider canals. So they're more prone to some of those injuries. But then again, they have a much richer blood supply as well. So healing potential around bones are much higher in children than in adults. And of course, we've got the actual growing centres of the bone, which again give us unique anatomical things which are important when we're talking about children, where we don't see those around adults as well. So we know that the ossification centres are 2 to 5 times weaker than the surrounding tissue. And it does actually change from certain research according to when you're growing in your maturity stages. So certainly weakest at the peak height velocity changes rather than more stable times. And we know that children through different times will go through different height velocity changes as they go through. So we've got to think of those type of changes when we're talking about the anatomical differences between children and adults, and therefore the different types of injury. And I'm sure we'll hear a lot of those different types of injuries as we hear from the different speakers as we go through this session. But we also got to remember that it's not just anatomy that is a difference here. There's also physiological differences between adults and children. They've got much less thermoregulation, they're much more prone to hypothermia, they've got a higher threshold for sweating, and all these things they're more prone to heat injury. They're more prone to certain illnesses that come through in children as well. So you've got to think of them in those ways, as well as the anatomical differences, those physiological differences when we're talking about children. And this really leads us to a whole different set of different things which we need to look out for in children. So the injury patterns, the avulsion fractures, are going to be there within the children because we know that the bone is going to be weaker than the ligaments and the tendons which attach to them. So we've got to think of different types of injuries which occur in children. But also, and we heard this earlier today with some of the speakers at the first session today, childhood cancers. We know that most children, when you ask them about a pain that's come, they will relate it back to an injury. And we can see that in 40-50% of the studies would suggest that when they pick up a cancer injury, a cancer diagnosis, they actually relate it back to an injury which has occurred before. So we need those wide-angle lenses when we're talking to children and really understanding that they may relate it to that particular injury, but it doesn't necessarily correspond to that, and look out for those childhood cancers, which are much more common around those ages. And then the final one is around non-accidental injury. And it really is very important to all of us that we're on the lookout for this in all the areas that we work in, including physiotherapists and all the way down through all age groups. Because it's a terrible thing if you miss a non-accidental injury and the child continues to suffer for longer and longer terms until it's picked up. And so it is down to all of us to pick those things. And we've got to be aware of the different types of child abuse that can occur. So it's not just the physical injuries we need to think about. When we're talking about teen medicine and we're talking about academies and other profiles, it is around emotional and neglect type of things which can occur as well. And the emotional one obviously can be really important when we're talking about sports children who really feel they're going to go on to other things. And it's often not the child, it's the dad or the mum who are really pushing that child into areas which they may not want to do, especially around injuries and getting over injuries and them wanting to get back in because they need to make the next tournament because that's going to be their next big breakthrough. So we need to be really observant of these things, think about the signs and report it through the structures which should be present in all our organisations now. We also need to think about the child sitting within their peer structure. So children develop at different stages, and we need to be very cognizant of the fact that they will have differences in terms of their secondary sex characteristics, their cognitive changes. We know the sort of grumpy teenagers and how they sort of go through different maturity statuses, and we need to think about those when we're treating a child and an adolescent. We need to think very closely about how they fit into their social structure. Just saying to an adolescent to go out and train, for some will be great and they'll overtrain, but for some they just won't see that and they won't understand how to do that without some peer pressure or the peers maybe pushing them in other directions. So we need to think of those adolescents and those children within those structures of their life. And then finally, what I want to just point out is that it's incumbent on all of us to keep people in exercise. We know the benefits of exercise, and we know the biggest fallout time, especially in children, is around the adolescent, in females, is around the adolescence. And this is the peak time for them to start to give up sport, start to give up exercise. And it is really important that we encourage them all to continue in exercise, to continue to get those life benefits. Even if they're not going to end up to be the world's best athlete, there is exercise that they can do to promote their own health being. And it's really important that we carry on promoting that through all our interactions with them. So in summary, for me, adolescents are different. We need to carry on encouraging them to exercise at all time. We need to think about the specific injury patterns and the specific issues around things like neglect and abuse in children, and understand the specifics of this age group. Thank you very much.
Good morning. This is a bit of a hobby horse of mine, so forgive me if I rant. And forgive me if I'm teaching my grandmother how to suck eggs. We're going to talk about adolescent sports-related stress injuries of the spine, but we start every spine talk with the red flags from the Royal College of General Practitioners. Any patient in front of you isn't an athlete, they're a human being who happens to play sport, so remember the red flags. Miss a red flag in a child, you'll never forget it. I've had my bacon saved numerous times by radiologists pointing out things on scans I'd missed that turned out to be something very important. What is a spondylolysis? Well, it's literally an incontinuity of the bone. It's acquired. If you look at a newborn fetus anatomically, or you look at adults who have never ambulated, they don't have spondylolysis or stress fractures. So it's an acquired injury. It's the commonest cause of low back pain after mechanical back pain in a sporting population in adolescents. Mechanical back pain is still more common. In my practice, which I'll present, spondylolysis is more common because obviously I don't get referred the mechanical back pains. It's a repeated submaximal force. It's not one episode. It's not the I jumped off my garage. It's doing the same thing again and again. It's either doing something right too many times or something wrong not that many times. It's more common unilaterally than bilaterally. 95% are in the lower 3 lumbar levels. It's increased frequency if somebody in your family's had it. 2 peaks in juvenile years and in adolescent years. Most are asymptomatic. It varies according to race, and that's to do with physiognomy. It's more common in men, and the sports are represented according to their frequency of extension loading. Now, where does it come from? It's our fault. It's adults' fault. The responsible adult hasn't been responsible. Basically, the child has overtrained or inappropriately trained or not had enough rest. And once they have an injury, they've been treated like an adult and not treated like a child. That's why these things progress. Typical school rowing program. I ask all the kids, what do you actually do in a week? And they tell me, and basically it's too much time being loaded and not enough time preparing your body to be loaded and having no rest in between. Rugby, similarly, if you hear a group of 16-year-old rugby players talking, one of the questions that will come up is, how much can you bench? That's not very sensible, but that's the kind of thing they're doing. Now, the key message is, most of them heal. A unilateral stress fracture is very likely to heal if you wait long enough. Impatience is not an indication for intervention. If on radiology, early stage CT changes, so it's an incomplete fracture or a bony stress response, and it's still got high signal on MRI, so it's a recent injury, it's very likely to heal. If it looks like a non-union on the CT scan, then it's not going to heal. It's worse if you're female, multi-level, bilateral, or if it hasn't been picked up for the first 6 months, and that's our job to pick this up. Well, how do you make the diagnosis? Well, if it looks like a duck and it quacks, it's a duck. An adolescent child with back pain who plays sport has a spondylolysis or stress reaction until you've proven they don't. It's often progressive onset, relieved by rest, initially intermittent, becomes continual when they're ignored and they carry on exercising. There may have been a change in surface or change in strength and conditioning. Examination findings, they may have tight hamstrings, they may stand with a simian stance, but often they don't. Stalk test, very sensitive, stand on one leg, extend, rotate towards the side that's painful. If it hurts, they've got posterior element pain. Spondylolysis is likely. Get them to do the same thing, hopping, that's even more sensitive. That'll irritate things. They may be tender. Investigations, X-ray, the Scotty dog, beloved of medical textbooks. Not sensitive, not specific, it's radiation, shouldn't be used. MRI scan, it's more sensitive, not so specific, and it can indicate some form of biological activity, and it's radiation-free. This is my chosen investigation of first choice. You get high signal, Gajan's here to talk about these things, so I'm not going to go into this, but there's something funny going on there. It's white. I'm an orthopedic surgeon, and I can see there's something wrong. And here you can see bilaterally high signal. CT scan is the next level. It's not used for initial diagnosis. It's used to characterize the fracture. Is it a stress reaction with no fracture? Is it a partial fracture? Is it a complete fracture? Is it an old fracture that has moved to a non-union? Or is it moving towards union? If you have a high index of suspicion but you haven't picked things up, you could think about a bone scan. Clearly this has higher radiation exposure and is not particularly anatomically or pathologically specific. But if something lights up, that gives you somewhere to focus on. A SPECT scan is obviously more anatomically specific, but again, more radiation exposure. A SPECT CT scan, even better, but that's a lot of radiation exposure, and normally they're not required. There are 4 radiological stages: stress reaction, an early fracture, a complete fracture, and basically terminal, which is a non-union. How do you treat them? There's an escalator of treatment. The vast majority heal without invasive treatment, so you try non-invasive treatment. It's an overuse injury. Use your common sense. Stop using. Shut down. The answer to the question, can I do this, can I do that, is always no. It's rest. It's not kicking a ball around with your friends. It's not a bit of exercise in the gym. It's shutting down. Get the pain to settle. Give them analgesia. Take the time to assess radiologically. I'm quite happy if the radiologists take time doing the investigations because that gives you an opportunity to rest. So people aren't pressuring you to make the decision on when they can return to exercise. More rest. Keep coming back to rest. If in doubt, wait. Pain relief. Simple analgesia, not anti-inflammatories. There is some theoretical possibility that anti-inflammatories could slow bone healing. It is theoretical. Targeted injections. Only for extreme pain or in extreme circumstances. It is not to allow them to exercise. Once they've settled, you get them back to rehabilitation. It's core exercise and it's cardiovascular. You move through these stages. You start with isometric, through isotonic, and you end out with sport-specific and movement patterning. Very important. That's how you prevent them injuring themselves again. Doing the plank for 10 minutes isn't going to help them to be stable running around a football pitch. So it's important to be sport-specific. Cardiovascular, you start with non-impact, aqua jog if you've got such a thing, such as they do at Chelsea, and you move all the way through to running and sport exercise. If each child could have a specific bespoke programme for rehabilitation, it'd be fantastic. This is, I think, the ECB Return to Cricket programme. It doesn't have to be that detailed, but something for the child, for their age, would be appropriate. Bracing, controversial. Not a lot of evidence. People have used extension braces and braces that prevent extension. Some people swear by them. But remember, if it's a mid-lumbar stress fracture, you need an LSO. If it's a higher lumbar fracture, it needs to be a TLSO. And if it's an L5 fracture, you need to include the leg. Well, no one's going to prescribe that, and no one's going to use it. The use of exogen, or low-intensity pulsed ultrasound, very little evidence in spondylolysis. People do use it, but it's not evidence-based. Vitamin D, check the vitamin D. If it's low, supplement, otherwise I wouldn't bother. Parathyroid hormone, there's no evidence. Further radiology, I treat them symptomatically. If they're improving, I don't image. If they're not improving and it was a partial fracture, I'd repeat the MRI. If it's a complete fracture, CT. Try and reduce radiation. Surgery, very rarely needed. It's needed when it's not diagnosed early, when they have continuing pain, and when everything else fails. The aim is to restore anatomy. Try and reconstruct anatomy rather than major surgery. There's different ways of doing that. You can do it at multiple levels. Quite a high complication rate, quite a high neurological injury rate. You get non-fractures with screw breakage. This is my group, 480 patients. Most of them turned up with spondylolysis, a few with discogenic pain, less mechanical. These in football, mostly stress reactions, some partial fractures. All of them managed conservatively, all got back without surgery. This is the period of time that I would expect. Offload for 4 weeks, return to play 6 to 8 weeks. For undisplaced stress fracture, 2 to 3 months, return to play 3 to 4 months. Complete fracture, longer, 12 months. This takes time. Remember, back pain in adolescent is a stress fracture until proven otherwise. Rest is the cure. Don't overtrain. Don't train inappropriately. Idiopathic scoliosis doesn't cause pain. Remember the rehab strategies, remember the treatment options. Don't diagnose sacroiliac dysfunction in a child, you'll be wrong. And don't diagnose piriformis syndrome in a child, you'll be wrong. Forget the red flags once and you will never remember it, never forget it. If you have a child die because you've missed it, you will never forget that. There's no place for prolonged manual treatment. And when they get back, rest. I'll leave you with that.
Damian, thank you. I never thought you'd actually make that number of slides in a 9 minute.
I have no disclosures. And the objectives for this session are to look at stress injuries and why they're different in adolescents. A lot of that's been covered by Julian already. And then look at imaging in the management of common stress injuries. Wolff's law states that bone has plasticity and it will adapt to stresses placed on the bone. That's common in elite sport. And when you get beyond a certain point, you get mechanical failure of the bone and a fracture. But what's different in adolescence? We've already covered it really, but it's zones of weakness due to the fact that the bone is growing. So it's very nicely demonstrated in radiographs, even more nicely demonstrated in MRI. And MRI is a really good test for looking at stress injuries. This has already been explained by Julian, but essentially the sites where the bone is growing acts as a zone of weakness, and it's particularly this hypertrophic zone of newly forming cartilage that acts as a zone of weakness where injury can occur. The other areas where stress injury occurs is apophyses, which have a very similar anatomical alignment, and they're the sites of attachment of tendons, and also the subarticular bone where you get osteochondral injuries like this one here. The apophyses, the only thing to say is that they're multiple, they're all over the body, and at the site where tendons attach to these bony attachments, we get injuries, and they can be predominantly found in weight-bearing joints around the pelvis, around the knee, and in the foot. So what actually happens? Well, it depends what type of injury as to what happens to these zones of weakness. So it could be traumatic or overuse related. At the muscle tendon bone unit, we get apophyseal avulsion in trauma and apophysitis in overuse. At the articular cartilage level, we get osteochondral injuries or fractures in trauma and osteochondritis dissecans in overuse. And in long bones, we get Salter-Harris fractures in trauma and stress fractures in overuse. And for my talk, I'm really going to follow on from Damian's talk and really focus on stress fractures, because in my practice, that's the thing I get asked about most in terms of what to do with regards to imaging, because these are young patients. We want to limit their dose as much as possible. And I'll try and demonstrate some of our thinking as to why we recommend certain types of imaging. So we're going to focus on the pars interarticularis with regards to stress injury, because it is the most common stress injury in adolescents that I see, particularly in cricketers and footballers. And we'll start off by looking at imaging modalities that we can use. So this line represents the passage of time. Everything to the right of this arrow will be radiological studies, and everything to the left of the arrow will be nuclear medicine studies. So we start off with the X-ray. Damian's already very kind of nicely demonstrated that we can see stress fractures with X-ray. The problem with X-ray is we see it late. We only see it when there is a fracture, and that's too late for us. We're looking at elite athletes. We want to pick it up as early as possible so we don't get to a stage where there could be non-union. So X-rays in history were good, but they're rubbish now. Bone scans, Damian mentioned, sometimes we use them. I think, generally speaking now, we would never use them. The reason being is that they are relatively high dose, and they're not very useful anatomically to localize, particularly in the spine. You get a little blodge of high uptake where the radiotrace is showing increased bone turnover. Very difficult to localize level, which side, and things like that. CT then came along. CT is very, very good and probably the best test for characterizing a fracture. But again, we don't want to get to the fracture when we're trying to assess these patients. We want to get to them before the fracture, and it doesn't show bone edema. It doesn't show the injury before you get that fracture. But it is good at characterizing fractures. MRI is the go-to test. The reason MRI is the go-to test is that it has no radiation dose, and we'll talk about that later. It can screen the whole of the lumbar spine, so often these patients will have low back pain, but we're wondering, is it an L5 stress fracture? Could it be an L1 stress fracture? So it can cover the whole spine, and it shows that bone edema of a very early stress injury. SPECT is basically a bone scan, but it's a 3D bone scan. So the main advantage of SPECT over bone scan is just that it localizes the abnormal bone turnover better, particularly in the spine. But actually, it's exactly the same thing. And then more recently, we have this hybrid imaging where we're fusing a radiological study which shows anatomy with a functional study which shows bone turnover. And so SPECT CT has come into play to show increased bone turnover and then correlate that with the CT findings of, is there a fracture where there is abnormal bone turnover? And we'll talk about whether that's useful or not. So next we're going to move on to what happens with a fracture. And stress fractures are essentially an evolution, a spectrum of abnormality that you see. So you start with the normal appearance, and then we move on to an evolving stress reaction. And in this context, we will see on MRI that we just see bone edema within the pars interarticularis and no evidence of a fracture. When we get to an incomplete stress fracture, what we see is on CT, we see a discrete fracture line. But it's incomplete, meaning that it doesn't involve both cortices. With stress fractures of the pars interarticularis, the inferior cortex is always involved first. And what happens is the fracture propagates superiorly to involve eventually the superior cortex if it gets that far. So with a complete stress fracture, what we see is a lucent line passing through the whole of the pars all the way to the superior cortex. Then what we hope is that we spot these stress injuries and then we rest the patient. And then what should happen is you get healing. And as you go through the healing process, what we should see is a reversal of those features that we saw. So we see bony infilling at the top of the cortex first, and then as the patient heals, hopefully all of that fills in with bone. If we don't allow the patient to rest, then what will happen is as you get to this complete stress fracture, we can end up with a non-union. And the difference between a complete stress fracture and a non-union is that the bone ends become corticated and marginalized and rounded, and this thing is never going to truly heal with bone. And what you tend to get is either non-union with nothing really, potentially movement there, or a fibrous union. So what is our strategy for imaging these patients? It's all based on what will screen them for their injuries and what will give them that, given that they're an adolescent patient with the lowest dose. So the first line imaging could be an MRI, a full CT, or a SPECT CT. Full CT we don't want because it's not going to show that early stress injury. So we're really talking about, do we start with an MRI or do we start with a SPECT CT? If we look at the literature out there, what it shows is that actually the majority of studies show that MRI is equivalent to CT, SPECT CT, in terms of diagnostic ability to pick up stress injuries. there's only one study showing one is better than the other. So for that reason, if we now go on to doses, if we look at what happens with regards to these studies, you can see that a full CT, which we would never do, has the highest dose compared to our background radiation, which is 3 millisieverts. A SPECT CT is relatively high dose, whereas the limited CT, where we just focus on one level, is lower than an X-ray. And the best thing to do, clearly, is an MRI scan. So given that, we can get rid of those two, and we can start with MRI as our screening tool. If the MRI is normal or shows a chronic defect, we need to do nothing further, and then we can manage the patient clinically. If the MRI shows multi-level pathology, then our question is which of these things are pain generators, and then it may be appropriate to do a SPECT CT to try and figure out what the problem is. If there's some other finding on the MRI, for example, there's a disc bulge or something, then we would image as required. And then finally, in the most common situation, if we have an acute abnormality, i.e. bone edema, or we're wondering is there a stress fracture here or not, then we would go on to some further imaging to characterize further. So what can we do to do that? Well, really we've got two possibilities. We either do a limited CT, so where we see the bone edema, we do a limited CT just at that level, or we do a SPECT CT. So what's the difference? Well, this is a standard CT which shows an incomplete stress fracture of the pars interarticularis. And this is the equivalent CT from a SPECT CT. And you can see that the SPECT CT is a lower resolution study. So if we're not interested in the nuclear medicine information of is there bone turnover or not, there is no advantage in using the CT from a SPECT CT. And we would always do a limited CT because it's much lower dose. So that's the thing to do next, is a limited CT to characterize the fracture and how far along its spectrum of abnormality it is. And then the next question I get asked is this healing? Is it getting worse? What's going on with the fracture? And how long do we need to rest this patient for? And it's difficult. So if we look at this fracture, you can see that it's not as lucent as that example I showed you. So is this healing, or is it just started and is it about to get worse? Impossible to tell. And the only way we know is with serial imaging. So we only find out that this is 3 months post-presentation. And if we then look at the presentation study, we can see that at presentation it was much more lucent at the fracture site. Therefore, this is healing. Now, does it really matter? The point would be if you scan them at time 0 here, all you really need to know is they need to rest and hopefully it's going to heal. But if you really needed to know, is this getting better, what you do is do an interval imaging. So that's what we would do next. And then in terms of follow-up, what do we do? Well, we would potentially do anything, but as Damian said, the ideal situation is to manage clinically. I'm almost done now. Only last thing to say is that the other injuries that we mentioned, which would be apophysitis, the extra thing that we can use is ultrasound. And all I really want to mention is that when you have an apophysitis, we can see very exquisitely the abnormality of the tendon rather than the bone. And so absolutely no dose attached to that. That's what we would do in preference. And with that, I'd like to end. Thank you very much.
Hip pain in adolescents is actually really quite rare, but I can assure you it's not normal. Actually, I find adolescents struggle to gain access to healthcare. I think they have a lot of obligations to their school and school sports. There are family holidays, the availability of parents come with it through consultation. I'm also amazed, as we've alluded to already, how much sport these kids are doing, but also how willing they are to participate in sport despite really very severe pain. They think, oh, if I just rest a bit or grow out of it, it'll all just go away. And that's a sort of a belief that's held not only by the teenager and their parents, but quite often by their healthcare providers. And they may see all sorts of people. They see general practitioners, physiotherapists, maybe the school nurse, the team coach, or the sports teacher. And there seems to be this willingness to persist with treatment without a clear diagnosis and a resistance to imaging them. Now, there's clearly a whole load of teenagers that have pain on the background of childhood hip disorders, which is, I think, outside the scope today. But I'm really going to concentrate on a sort of development of chronic pain in hips. I'm going to just briefly talk about acute onset conditions. I mean, this is 9 minutes in itself, really, at least. But if a teenager has an acute injury around the hip, it needs some kind of imaging, at least an X-ray and probably an MRI scan. It gives you a lot of reassurance about what you're actually dealing with. This is a scan of an Eton schoolboy who pulled his hip at the beginning of the cricket season, and it reassuringly shows a nice injury to the obturator externus. We can all relax, it's nothing terrible going on here. This is the classic apophyseal avulsion that we've seen already. But X-ray is so important. This young man had slipped up femoral epiphysis, age 15. He was treated for 2 months without any imaging. And sadly, it all went very badly, and he had a hip replacement 18 months later. So please image these teenagers. I'm mainly going to talk about gradual onset of pain, because if you get a gradual onset of pain in the hip, it's usually something bad is going on. And what these teenagers get is injuries to their acetabular labrum, as well as the anterior part of the articular cartilage. So here we are looking inside a hip. There's a cartilage flap there already, and there's an acetabular labral tear. This is a 17-year-old. Now, they get labral tears either because they're very mobile, and they're certainly the minority, but usually it's because of hip dysplasia or hip impingement. Now, the presentation is very, very characteristic of an acetabular labral tear, and I'm far more interested in taking a history than looking at a fancy MRI scan that may or may not show a labral tear. They get a sharp catching in the groin. It's very characteristic. If they describe a catching or a pinching, that's an acetabular labral tear. They will localize the pain using their thumb and index fingers, and I'll just walk here, and they'll tap it over the front of the hip. And that's called the C sign. They may also just point with a single index finger where it hurts. And then a key characteristic is the difficulty sitting. And this actually can be quite a problem for education. They can't sit in lessons. I've even had to do letters so that they can sit and take exams and walk around in the middle of an exam. They may be on painkillers, and these are significant symptoms for these young people to deal with. The pain develops gradually. The usual sports are those involving twisting under load, so the usual suspects are rugby and field hockey. It starts off with a post-game ache, then it becomes an ache at half-time, then it becomes an ache sort of all the time, and may actually even be painful just walking about. If there's hip dysplasia involved in females, there may be some instability. Examination-wise, as well as the description, the localization of the pain, their hypermobility may be an issue in young females, and the impingement test. The impingement test, what you're trying to do is you're trying to aggravate the labrum by bringing the front of the femur up against the edge of the acetabulum with flexion, adduction, and internal rotation. And it's positive it reproduces the teenager's symptoms. So I looked at my own data for this, and over a three-year period, and actually I operate on over 20 teenagers a year, which surprised me how many. The ratio of females to males 3:1, and that's because of dysplasia. And the usual operations I'm doing are pelvic osteotomies for dysplasia, or arthroscopic treatment for labral tears and impingement. And what surprised me was how many hip replacements. So we're going to get a Columbo slide at the end just about hip replacements in teenagers. But so the acetabular labrum is torn in hip dysplasia because the hip socket is shallow and upwardly sloping, and so therefore the labrum bears all the brunt, and it eventually tears. And not only does the labrum tear and symptoms develop, but there's more pressure on the articular cartilage, and actually this is a pre-arthritic condition, and it's the commonest cause of hip replacements in young women. It's hip dysplasia, so it's important stuff. The operation we do for this is in patients with severe and persistent symptoms is called a periacetabular osteotomy, or PAO, and it looks pretty horrific, but I promise it's fine. I do it all the time, it's safe. You cut round the hip socket and literally you reposition it so that we're moving the hip socket from here onto the top, and this dramatically reduces the forces through the joint and also relieves pain critically. In the long term, obviously it'll delay or even prevent them getting arthritis completely. This is a pre- and post-op radiograph, and you can see how much of the femoral head is now within the socket, having rotated the socket round. And this young lady went back to full sports and basically effective normal hip function. It won't last her for the whole of her life, but she'll certainly get through the first 20 or 30 years. Now, hip impingement, again, causes an injury to the front of the acetabulum and the acetabular labrum, and it's due to recurrent conflict between the femoral neck and the edge of the acetabulum. In the sort of more common male sort of cam type, it's because of this bony prominence at the head-neck junction, grinding on the inside of the acetabulum, causing shearing of the articular cartilage and damage to the labrum. So it's pre-arthritic. The pincer type that's more common in females is due to prominence of the anterior rim of the acetabulum, and that's far more a cause of labral injury, but it's not a pre-arthritic condition, although it is very painful and because of the constant pressure on the labrum. So again, if you've got persistent symptoms that are not getting better with conservative treatment, we do surgery, and fortunately these days it's arthroscopic surgery, so it's again 2 weeks on crutches, day case or overnight stay, and what we do is we repair the labrum and we correct the bony deformity. This young man, he missed Henley this year in the last year of school because of his cam impingement. There's the bony prominence, which is disappointing. So that's the inside of his hip, their labral tear. This is, say, 17, so that's the labral tear. And again, he's also got some articular cartilage damage, just starting there on the edge. It's actually quite a mild one, but I mean, I've seen teenage rugby players with actually full thickness flaps already as teenagers. So this is a pre-arthritic condition. And what we do is after that, then we reshape the ball so the ball is nice and round. And that's really a very effective surgery. So I really want to emphasize to you that this, do surgery on these adolescents. It's important to correct their bony deformity so that it relieves their pain and also will improve their mechanics to delay or prevent arthritis completely. Delaying surgery only leads to more damage, and I think that's a critical take-home message. It's safe and effective to operate on these teenagers. They get well, and they're going home to the nice, safe environment of their parents, who will then take them to physio and hydro. So they get better really, really well. Now, I can show you, numerous papers showing the results of this kind of surgery. But these are actually my results, and these are results using the tool of the non-arthroplasty hip registry, which has been going for 5 years, and basically it's like the National Joint Registry for joint replacements, so for non-arthroplasty hip surgery, so hip arthroscopy and osteotomy. So these are and what this clearly shows is that hip function and pain improves, as does their quality of life by, on health-related measures. And the only disappointing thing about this slide is that the compliance of these teenagers in filling in their one-year questionnaire is only 40%. Which in the digital era is slightly disappointing, really. It's marginally better than for the general, which is about 35%, but it's a patient behaviour thing. Now, this is my Colombo slide. The hip replacements are required in adolescents. And if you're thinking of doing a hip replacement in an adolescent, basically it's usually on the background of avascular necrosis from childhood malignancy or sickle cell disease, or from repeated failed surgery for childhood hip disease, such as dysplasia and Perthes disease. And these children they've never had a good hip. Their life's always been affected by it. And they're on strong painkillers, they can't go out, they can't socialize, and it affects the whole family, actually. And with modern ceramic on ceramic hip replacements, really they're incredibly durable. They last at least 20 years, and I'm only saying 20 years because they've only been around for 20 years, but they look fantastic, performing really well at 20 years. And it's no longer true that you can be too young for a hip replacement. It's just not true. You're never too young for a hip replacement. And hip replacement actually transforms the lives of these crippled children. So I just want to emphasize, it's not normal to have hip pain if you're adolescent. Please image and scan them. Listen to the story of a labral tear. It's very, very characteristic. Adolescents are fun to operate on. They tell you stuff that you may not know otherwise, that you can impress your children with, and but bone deformities cause cartilage damage and arthritis. Thank you very much indeed.
Thanks, Julian. Thanks very much. So it's a pleasure to be here. I have no relevant conflicts to declare. I'm sure many of us have managed children, adolescents with posterior heel pain. In clinic we see them, we think clinical diagnosis, simple diagnosis, Sever's disease as we most commonly call it, and some suitable offloading and relative rest will get most of these guys better. So I just want to use this opportunity to throw up a few questions on what do we actually know about this condition, and what can go wrong, when do we image, and so on. So what's the apophysis? It's already been mentioned. So in the calcaneum and the posterior aspect, it's a secondary ossification centre where the Achilles tendon comes and attaches there. It opens at the age of about 7 and closes around the age of 15. So people outside of this age tend not to get this condition. If it's outside of this age range, we're not probably dealing with Sever's disease. And this is an area of zone of weakness, as my colleagues have described, and it's thought to be less load tolerant than the adjacent muscle and tendon attachment. So it's a potential area of vulnerability. Now, there's a couple of main theories as to why people get this condition and what's actually going on. So repetitive microtrauma to this area is thought to be one key factor in this, and a series of MRI scans on this age group by Ogden has shown that actually the area of edema is not just confined to the apophysis, but actually it can also go on to affect the metaphysis as well, which supports like an overload, an overuse sort of theory. The traction apophysitis is another term to describe this condition. That's derived really from some evidence that Lieberson produced. He looked at cadavers and CT scans of this region and found a concentric pattern of bone, essentially, which supports the fact that the Achilles calf complex may be applying an overload sort of feature to this area. So there may be more than one mechanism going on. We don't really know for sure. And therefore, the situation of a tight gastrosoleus, in which many of us try and suggest, let's stretch this out and try and reduce the forces going through this area, seems like a sensible thing to do. When the condition was first described by, it was actually, Sever is the one that's known to have described this condition in 1912, and he described an inflammatory condition. So this American chap actually took all the credit from Haglund, who actually described it much earlier, 5 years earlier than him. So who does it affect? Obviously, we know the age range. It's not an uncommon finding, even in primary care, for this age group to present to their GP. The GP will diagnose it clinically, manage them, and most of them will get better. There's only one prospective study on this condition, which looked at around 70 adolescents and compared it to about 200 asymptomatic adolescents. There's been theories regarding overweight. Is that a factor? Biomechanical foot posture, so perhaps overpronation or a high arch, and even certain sports, do they predispose? But actually, in this only prospective series, none of these were found to be conclusive. So although we associate it with these potential features, we're not really sure about it. And even the amount of sport people do. So, you know, you would imagine that the more sport and more activity they do, the more likely they are to get this. But there isn't that sort of trajectory in terms of hours of sport played per week. The clinical presentation, most of us will be familiar with. It's an insidious onset of pain. It's worse with exertion, and it can get worse if you keep on loading the area. There may be some morning stiffness, and over half our patients will have bilateral symptoms. There's been a study looking at the impact on physical activity and mood, and it's thought to be quite significant, essentially. In our clinic, we'll see them, and we'll see potentially that there'll be pain on hopping. Passive dorsiflexion of the ankle will also reproduce symptoms, and they may even come in limping and toe walking to offload that area. The most sensitive test, or clinical test for the condition, is the squeeze test, where you pinch the medial and lateral aspects of the calcaneum, so you're away from the Achilles tendon, just compressing the apophysis specifically, and that's thought to be the most useful diagnostic tool. Is imaging necessary? Well, people have used X-rays, MR, CT, etc. The difficulty with the imaging, and there'll be other speakers that we can talk about this at the end, is that the features seen in calcaneal apophysitis essentially can be a normal variation of normal growth. So it could be asymptomatic. So widening of the apophysis, fragmentation of that apophyseal area can actually be just a normal part of growth. So it's not very sensitive or specific to help us diagnose Sever's disease. Imaging is probably more useful in excluding the differential diagnoses, really. So the unusual presentations, the severe cases of severe pain, we probably want to image. MR is also being used, but also you often get high signal in the apophyseal area in a normal growth. So the use of it is probably more in excluding other differentials. On ultrasound, again, you can see the fragmentation quite well, and it'd be quite useful to exclude any Achilles problems, particularly in the higher age group when the Achilles problems may start to begin. So if you think that this is a severe case, you probably may need to immobilize it for a very short period. You probably want to image, and that might be one indication. In terms of the treatment options, I mean, there's been many described. So James did a nice systematic review of the modalities, essentially. But within the literature, there's only 3 randomized trials, and they both looked at foot type, footwear, orthoses, and to summarize them, really, they've even gone as far as to say load modification may not be necessary. So there's some reasonable evidence. It's only a small study, but a heel cup may be just enough to help disperse the load in the calcaneal area, and therefore offload the area sufficiently with the adolescent potentially carrying on loading and playing some sport. So the natural history really is one of, so the condition can resolve symptomatically. That's what you want to try and achieve within a couple of weeks to a couple of months. So that's the usual sort of time frame, but there can be recurrence, and that's been reported at 20 to 30% in the literature. So once the ossification centre is fully mature, you shouldn't be getting symptoms of Sever's disease, unless there's a complication. Now, complications tend to include an avulsion fracture at the posterior calcaneum, and that may need a surgical opinion, and whether you need to immobilize that or operate. If there's an associated Achilles tendon tear, again, you probably see that on ultrasound or MRI, and that may need a surgical opinion. Or recurrent and persistent symptoms, again, maybe refer them as well. Prevention, there's no literature on prevention. I mean, how do we prevent these things? There's only some pragmatic advice here, essentially, because there's not much evidence behind it. So maintaining flexibility, avoiding excessive load, and advocating cross-training probably are helpful, and early recognition of the condition. So early presentation. The problem with this often is that they've had this problem for many, many months, and therefore probably it's going to take proportionately longer to settle down. So in summary, so calcaneal osteochondrosis, probably is a better word, is diagnosed clinically. There's little support for any pathophysiological mechanism, and even in treatments, there's very little supportive evidence. It's invariably self-limiting. I think patient education is the key to it, really. Consider imaging if it's unusual, refractory, or a severe presentation. There's no role of injections. Injections have been mentioned in the literature, steroids, etc. It's just not a role here, and surgical opinion may be occasionally warranted. Really, if we want to understand this problem better, then we need to do more studies. Thank you.
I'm a strength and conditioning, and I'm going to focus on the adolescent dancer. No disclosures to declare. I'm a strength and conditioning coach. I've been working with adolescent athletes for the past decade, mainly netball, tennis, and for the past couple of years I'm focusing in ballet, where I'm completing a 3-year PhD study, and I'm in my final year this year. So what I do is basically I'm trying to make dancers stronger, and this is a very difficult task because they don't like the word strength. Does it work? I want to believe it does, and I'm trying to produce some evidence in order to eventually and potentially change practice in ballet, because believe me, there are a lot of things that are wrong. I would like to start by presenting a case study of a 19-year-old dancer who developed pain in the ankle summer 2017. She carried on dancing as it is something common that dancers do. They ignore the pain to the point of no return, where she couldn't do a calf rise on the injured side. There is a typo there, December 2017, not 2016. She had some manipulation from another physio, and she thought that she was resolving the problem, but a couple of days after the manipulation, the pain was coming back. So then in December, she saw Dr. Nick Allen in Birmingham Royal Ballet, and this was the diagnosis. So what Nick Allen said to Jade was that we can avoid operation if we get stronger. So this is a fast-forward video that I put together for the dancer as a motivational tool and as an educational tool for the younger dancers, just to show the rehabilitation process and what we put together. And I never thought that this video was actually going to become very successful and it was going to be circulated around the world in the dance community. So now I'm a strength coach who's a superstar for ballet dancers. It is not true, because I don't believe I have reinvented the wheel. In sport and in elite sport rehabilitation, this is the given. But in ballet, this is something that had never happened before, especially in adolescents. So the video link is there if the presentation gets circulated. So what we did is we looked into the biomechanics and we tried to offload the injured area. And basically we made the structure stronger so that she could take more load. And what is really important to remember is that this is a special population of high skill but with very low capacity, which makes adaptations look like miracles. So I look like a superstar in ballet because really they're so unfit that it was very easy to create adaptations. Then we had Dr. James Calder did a CT scan on Jade's foot, and the last sentence says, "No further action needs to be taken." Wow, I'm still a superstar. So what we have is no operation, improved performance, improved confidence, both in dance and in body image, which is really important for dancers, and we have a contract with the company. So far, so good. However, this dancer was diagnosed with sacroiliitis 2 years ago. And this was a secondary outcome from the intervention that I wasn't expecting. She was on anti-inflammatory pills and she couldn't exist without actually taking the medication. I have seen her getting carried out of a studio with a wheelchair because she couldn't walk. I asked her to take the risk to stop the medication, and she hasn't been taking the pills for 4 months. The mechanism behind this is shown in exercise and disease. So the exercise can have an anti-inflammatory effect. So this is shown in a heavy body of literature. So the IL-6 and its anti-inflammatory function, we know how it supports inflammation, but we know with the high-intensity exercise, it can work as an anti-inflammatory agent. But it doesn't last forever, and it needs to be topped up on a constant basis. I received a text a couple of days ago, and we have the same feeling in the back. So she hasn't been training for over a month because of high dance load, and she has lost the strength benefits of the strength training. Adolescents and elite performance, there is high demands for performance or curriculum, and there is lack of time to train physical abilities. So, to give you an analogy, in ballet, they look like Ferraris, they move like Ferraris, but the engine is a boy racer car. So it's an underdeveloped engine for high performance demands. And the reason for this is that it's the ballet-only approach, which in 2004, it was observed, but we are in 2017, and in adolescents, it hasn't really changed. So to show you how this works, the blue is the physical preparation time allocated per week. Can you see it? It's very small, because the green takes over. This is the dance hours per week. This is the effect that I see. Well, this is an observation. This is a cross-sectional study. This is unpublished data of mine where it's the jump height means of the females and the males, and the younger ones on the left jump a little bit higher than the older ones on the right. So they focus so much on physical preparation that in the end, the physical abilities don't get trained. So they lose the opportunity to teach their bodies how to jump, and they focus on how to look good while they're jumping. So what we also have is high prevalence of injuries, and especially overuse injuries. In pre-professional dancers, they can reach up to 70% and above. And what I'll give you, again, some unpublished data, 60% of 180 students had reported an injury by February 2017. So the season starts at the beginning of September, and by February, 60% of our students had reported an injury. Now, last year, I was privileged to be able to observe the kids actually breaking and look into maturation and overuse injuries. But again, this is unpublished data. What we also know from literature is that 50% of overuse injuries can be avoided if the correct strategy is followed. Now, some recommendations of specialization back in 1994 from Isurin, if you look into the right column, the yearly training volume in hours, and you look how the accumulation of hours per year increases, and there is a gradual increase of the chronic load, and then you look into ballet school, there is no such principle. They simply go for it. From the age of 12, 660 hours plus shows. Now, what is also interesting is that in adolescent dancers, every 6 weeks there is 1 week off, and every 12 weeks there is 2 weeks break. Then we have a summer holiday that is about 6 weeks, but the young dancers are always advised to carry on dancing, so they will probably do 2 to 2.5 weeks within their summer break. There is no focus on conditioning, apart from the odd floor Pilates class, so there is no force through the body. When we talk about chronic and acute ratio, the dance staff say to me, what ratio? They can't get the concept of increasing the load slowly. So in elite professional dancers, what we get to see is that there is a constant battle against injuries. We either try to reduce inflammation or avoid inflammation, but we're never running smoothly. Somewhere along the line, somebody's getting it wrong. But I'm not sure who yet. I know for definite that in ballet, the discipline is the driving force, and there is a lack of dance-centered approach. So in summary, I'd like to say that 50% of the overuse injuries can be avoided if the correct actions are taken. There needs to be a balance between technical and physical preparation. We definitely need to take advantage of the anti-inflammatory function of high-intensity exercise, and in particular, resistance training. And strength training can definitely improve confidence physically and psychologically, but we know that it can't solve everything. So thank you very much.
I'm going to speak to you today about rehabilitation of the young athlete. We don't have a great deal of time. Oh, there we go. This is my youngest, who you're going to see on a couple of slides. He was about 10 at that time. And there's a range of issues that people who are involved with rehabilitation, prescribing exercise, whether it's for treatment or whether it's for training, need to be aware of. We've got an expert coach. We've just listened to Nico, an expert coach who works with children. All of the exercise that we saw in the video was appropriate for children, believe it or not. You saw some weights and so on. It might have caused a bit of concern. It's all perfectly appropriate. But the further down the food chain we go, we saw Chelsea Football Club earlier on, the facilities, the level of coaches we've seen on the presentations, they all understand the issues. But I often work with people a bit further down the food chain. The coaches don't understand these issues. So I thought I might, just because we've got 9 minutes, go through some of those issues, and hopefully you'll find that quite useful. So if we look at the illustrations, we touched upon this, the child is not a mini adult. I often use x-rays if I'm talking to coaches to explain that. And coaches, non-medical stakeholders, might include also the athletes themselves, the children, it might include the parents, and as we said, strength and conditioning coaches and so on. So this is the important thing. Areas of growth within the skeleton, particularly musculoskeletal. It's very simple to point out to coaches that the skeleton looks a little bit different than with adults. We have got growth plates. The ends of bones are cartilaginous, not solid bone. Here we can see a pressure epiphysis with a secondary ossific centre. These areas where the tendons attach are cartilaginous in children, so they're different than in the adults. In fact, I want them to really realise that they're different. I want them to think of the structure as almost a little alien structure and realise that they're dealing with something completely different, a unique little animal that they're working with. So, in comparison to the adult, stakeholders need to understand the differences in morphology and anatomical structure, the way in which the developing skeleton responds to load, particularly at times during maturation, when those maturation areas will change, and I'm going to show you a couple of examples. So, imagine you're a group of coaches, you've not had our benefit of training, you've not had our anatomical learning, we've not had conferences like this, and then you put up with a young animal. So I thought we might use this. If I asked you this question, why should young elephants take care when kicking a ball? Coaches might answer, because we're not dealing with the finished article. They don't have the technical skills and movement control that you would see in an adult. They haven't developed the soft tissue resilience and sport-specific fitness. and they haven't developed the psychology, the understanding of that particular sport. And deficits in any of these areas would obviously cause injury. And coaches are aware of that. What they might not be aware of is that we're dealing with a different anatomy. So if we go to our elephant pelvis, this is the ilium. In an adult, we can explain that this whole structure is a bone. All the abdominal muscles, the lower abdominal muscles, the thigh muscles attach onto the bone. But in a child, they insert onto the growth areas. This is a cartilaginous rim. So they differ both microscopically and macroscopically. If the anatomy is different, then obviously the injuries that we see will be different. So they're dealing with a different little animal here. We can also explain that there's a chronology to injury. So if we look at a juvenile, the muscles that we're all familiar with, transversus abdominis, quadratus lumborum, external internal abdominal oblique, the tensor fasciae lata, sartorius, etc. In a young athlete, or a young elephant in our case, those muscles attach via tendons, via soft Sharpie's fibres, into a soft rim. They're tensile resistant, young children are not particularly strong, and they're usually quite bendy. So there aren't tremendous forces at that area, at that age group, so we don't tend to see many injuries. When we get to this, to the adolescent, the secondary ossific centres appear in that cartilaginous rim. The rim begins to calcify and subsequently ossify. The Sharpie's fibres, in themselves, if you ever read about Sharpie's fibres, are quite interesting. They change in their morphological structure and become a little bit more rigid. And at this stage, this is when we get these huge increases in power, and we also get huge increases in growth, which I'll show you in a second. And that causes tightness, power, and a shifting surface. They're almost like on shifting sand, I like to think about it. And this is when we tend to see the injuries. In the adult, as this area ossifies, this whole rim would ossify, the tendons then insert back onto bone. We don't tend to see the avulsion injuries as commonly as we do in children. So it's a small leap for the coach to understand the injury. Now, we don't need to go through very complicated pathological explanations. We just show them some pictures. And here we can see the injury quite clearly. It's obvious for the coach to see that compared to the normal. And it's beautifully shown on the CT scan. And I've learned a lot about radiography when I've been on some of these talks today, so it's been great. But these very simple images are very good. You don't have to have medical training to understand them. And we can see the avulsion injury quite clearly. So, implications for rehab. This is our Michael again. When he was 13, he was 5'10". When he was 14, which was about 15 months later, he was 6'3". That's 5-inch growth spurt over that period of time, huge amounts of growth, and he's a typical teenager. He's a bit taller than me now, which is a bit unfortunate. But anatomical risk factors we've mentioned, at that age we see an increase in power in that age and the limited flexibility that comes with that growth. And then we've got the developmental risk factors. All of that biomechanics causes changes in their dynamic control, the way that they do movement. And we've, I think if you were at talks yesterday, you heard movement patterning is a new term, but it's been used in sport for a long time. But the levers make a big difference to athletes. I don't know if you're a football fan, but there's a Manchester United boy, Scott McTominay. In the last 2 years, he's grown from 5'6" to 6'4". He was put forward as the next Wayne Rooney, the next best thing. But that huge increase in leverage has actually inhibited his development. He's had his first couple of first-team performances, been on for 5 or 10 minutes, but he's had to deal with these type of changes. So for coaches, it's relatively easy to look at any of those issues on the board there and relate them back to the developmental anatomy. And, I worked in football for a long time with the juniors at Manchester City. And, these are all probably obvious. Discipline is really important. One of the things the boys like to do is they like to run out of the changing room with a ball onto the pitch and whack it into the net, which is halfway down the pitch, which is a long way to kick a football, without any warming up and without any stretching. Very common with kids. Discipline. Once you explain to coaches the structure of the pelvis and why you don't want them to do that, then it becomes very clear. So linking things back to the developmental anatomy, again, is very important. So our second illustrated issue is the art of tackling. Part of a rehabilitation process is to teach in a sport the technique that can avoid injury, whatever the sport might be. And in our case, with football, we wouldn't want any of our juniors tackling. We don't want any of our adults tackling in this way, but we particularly don't want any of our juniors tackling in this way. The psyche of a player can come back into this as well, which I'll show you in a second. And again, our elephant can help us educate coaches and educate players. We can show the differences between the adult and we can show the differences between the child. And we can see the bone and cartilage interface, which is clearly seen on an X-ray. So imagine a high tackle with the foot planted, the foot's planted. I'm a teenager who doesn't want you to have the ball, so I'm going to do that. I'm going to plant my foot, I'm going to put my arm up there, and I'm going to go, and the other kid's just going to come straight through me with his foot up above the knee, hit me here. With an adult, he's already on his toes, and he's going to roll straight away. So he's not going to get injured. He's going to get a bruise, but he's not going to get injured. But with a child, we've got to be very careful. There are weaker things in the field than the ligaments. And this type of Salter-Harris fracture is very common in the scenario that I've just described, rather than an ACL injury, which you might see in an adult. So conclusions, the stakeholders in whatever capacity need to be aware of the unique nature of the developing skeleton, the chronology of maturation events, and injury patterns common to their sport. Can't get away without a quote. I wonder whether Bertrand Russell, did he observe over-aggressive stakeholders who didn't understand juvenile anatomy, leading to the injuries that we see today? So my final presentation message is understanding the developmental anatomy is key. After all, maturation is not a new process. That's a 1.6 million year old humanoid skeleton. We can clearly see the growth areas. If we're still here in 1.6 million years, we'll still have the growth areas, we'll still have the same injuries. And again, no disclosures. Thank you.
To kick things off a little bit, I could try and move on to the whole prevention and safeguarding issue that we face. So a lot of the injuries that we've discussed and the management that we've discussed, many of them seem to be preventable. And from a safeguarding point of view, I suppose we all have a responsibility to try and do something to prevent these injuries. If not, I guess we're partly guilty of child neglect. And I wonder, with all the challenges that go on with adolescent sport, you've got parents that can be hugely challenging. You've got coaches. You've got load management issues. You've got lack of access to S&C and often to rehabilitation. Specialisation in sport starts earlier and earlier and earlier in one sport. I wonder if you could each try and touch on a slightly different area that you think would be your biggest win to try and prevent as many injuries as possible from happening.
For me, one of my sports is football, and more often than not, we tend to get 2 or 3 at least spinal stress injuries, so bone stress of the facets in particular. And Damian's not here, but Gajan might have something to say. But and that causes a lot of time loss for us. So what can we do as a medic or a physician? I often wonder, with our new medical signings, we commonly do MRI scans of ankles, knees, hips, maybe lumbar spine, to look for any degenerative change, chondral injuries, etc. Should we be imaging, potentially MRI imaging, our adolescents at some point and looking to see, do they have bone stress? That's, if that's going to cause probably over a year's time loss from when you look at the number of players that are affected and the impact it has, should we just be screening them all from an imaging point of view? And maybe if people think it's ethical and it's something that could be advocated, I don't know.
I've got something to say about that, just in that I did a study with the Lawn Tennis Association a couple of years ago, and in the Lawn Tennis Association, all the adolescents that join the scheme get a screening MRI of their lumbar spine. And in that, they're all, in our study, it was all asymptomatic athletes with screening MRIs, and the number of PARS abnormalities we saw was huge. So those players would then go on to get prehabilitation to prevent injuries. So I think definitely something to think about.
Glad you raised the issue of safeguarding, because it was one of the first things that I mentioned in the ballet school, and I was frowned upon. I do believe that it is an issue, and the more knowledge we have, the more we can actually stress this, and education does help. But I feel it needs to start at a very young age, because I'm fighting against a discipline that relies on tradition and heritage, so that's very difficult to change. Whereas when I'm educating 12-year-olds, it's a lot easier to get through to them by actually having role models like the dancer who I managed to help avoid an operation. So education is the key, and also the more knowledge we can trickle down from elite, because dance science started about 25 years ago and identified the issues with dancers, and it's only now that we are actually getting into the adolescents in order to produce some data and potentially change practice.
For me, I think we need to get better at translation. So I think we've got a lot of really good research data, a lot of information that we collect, but the big problem is a lot of that sits in, I work in an academic institute part-time, and we've got a lot of information that we're not very good at disseminating. I think your video is a great example of trying to get information out there, and with social media these days we've got huge opportunities that I think especially as academics, and I take myself as part of that, we need to get better at translating the information that we're finding out to all levels of the sports population.
For me, it would be education, education, education. So obviously I'm a physio, I'm involved with undergraduate education and postgraduate education. But if I just give you one example, the Salter-Harris fracture that I just showed you, which in the adult would often cause the ACL, how many times do you see a physio or a young medic run onto a football field, and whether the player's banged his head, his elbow or his shoulder, the first thing he does is a Lachman test. With that injury, you wouldn't want to do a Lachman test. You saw that sharp metaphyseal spike, popliteal structures behind it, so if they didn't have a really nasty injury to start with. But that's education. That's just simply knowing what the developmental anatomy is.
Excessive or unsupervised weight training?
Always want to give a short answer like this. Thank you. I think for me, it's actually to do with when getting children when they're really young and they know what sport they're going to go into and understanding the movements that they're going to have in that sport, so that you actually start to train them very early on. And we see this a lot with a lot of different sports, rugby and football, around weight training. And actually, the weights aren't, it's not the important thing about the weights, it's the way they lift and the movements that they use to get that lift. And actually starting that at an early age where you don't call it weight training, you play games with the children when they're sort of 8, 9, 10. But what you're really doing is providing them with a movement memory for their joints and their bodies to get ready for the sports that they're going to get into. And I think that, to me, is the most important part.
I'll just make a quick comment on the weight training before the question. There's a lot of evidence about weight training in children, and it's something that physios in particular are very worried about and concerned about. Weight training is safe. It's a very simple mnemonic. As long as the child can perform the exercise correctly 10 times, then the weight is safe for them. The research that's been done is just a little bit difficult because it was first done in America for American footballers. And when I read the Rugby Football Union's guidelines for weight training in young athletes, they just copied what the Americans had said. It was almost verbatim, word for word. And there is an agenda there, obviously. Rugby clubs need lads to be very big, and they need them to lift very heavy weights, and they do start to push the boundaries. If you come one step down from that, I think weight training is very safe, but pushing the boundaries, I think, is really a bit difficult, and that's where we might get injury. You're never going to see a study about it. Who's going to test children to destruction and test the growth areas to destruction to see if the heavy weights damage them? You're not going to see it done. But in practice, I think if we all manage to get our figures together, we do see that type of injury.
So there's questions at the back, yes.
Hello, yes. Ben Thomas, I'm a consultant in spinal and pain medicine at Fortis, and I have a big interest in this age group. I'd just like to thank all the speakers for terrific talks, first of all. I just want to concentrate, Gajan, if I could just ask you one more question. That balance between dose and injury, and particularly CT SPECT, would you be able to give us an extra 5 or 10 seconds on where you view the benefit of that to lie from an imaging modality?
Yeah, so I'm not sure if she's in the audience, but Ranju Dewani is a radiologist that does a lot of SPECT imaging at the Wellington for elite athletes, and we often overlap, and there's often an issue with regards to do we do an MRI, do we do a limited CT and a SPECT, and I think looking at all the data, clearly, what I presented I think is the right way to go about it. So if it's a solitary level of injury, MRI first, the screen, and then a limited CT to absolutely minimise dose to characterise the fracture and work out how likely we think they need to be out for. But wherever you're in a situation where there's a quandary about, is this really the cause of symptoms? Is there multi-level pathology? What's the pain generator? Then that's really where SPECT CT comes into it and is really useful in that context.
Hello, I'm Sean Simonson from South Essex. This is mainly a question to Joe about the management of adolescents with rotational malalignment. It's been my experience that physiotherapy can help with pain and reduce pain and maybe even improve their gait pattern. But fundamentally, when these children get to a certain point, they don't return to the sports at a good level because they have a malalignment. And unless you address that malalignment, they physically can't achieve what they're trying to achieve. Is that your experience?
Yeah, I would absolutely agree with that. I think there's a surgeon, the derotational osteotomy seems like such a big procedure, I think, to say to somebody, we're going to break your bone, we're going to derotate it. I think to a lot of parents especially, they're quite shocked. But I actually think that we should probably, it's one area where I think we should be a bit more aggressive. The problem I have is, I've got a talk on it later where I go into a bit more detail about the way that we image. So actually our values of rotation, I don't think are very accurate at the moment. I think the only problem, because I work with surgeons, is that they're going to go in and do it, they need to know what the alignment is to then know what they're changing intraoperatively. So my target is to try and, I work part-time in engineering, so is to try and make it easier for the surgeons to make it a less aggressive, I guess, procedure for what it is for them at the moment. But I think it's got a huge role, and I've seen a lot of patients afterwards who really tell you that their good knee, which they've not had operated on, is now their bad knee.
You have to do bilateral. You can't leave one leg pointing out and the other leg pointing in. You have to do both.
So I break bones for a living as well. It's kind of okay. Please, I don't want you to be running away thinking that, it transforms these usually young women's lives if you realign them. It's an okay thing to do. It sounds all terrible, and as I say, yeah, their parents may raise their eyes when you say you want to break their leg. Boy, imagine if you want to break their pelvis. So, they get into it and they realise there's a community out there that can support them, and that's where social media is very helpful. And sadly, we don't have a big celebrity patient who's had a PAO, but Lady Gaga's hip arthroscopy was very helpful, in this. So it's okay. Surgery, they do well with surgery. The bones heal quickly. They're going to a nice therapeutic environment with their parents usually. And so if you need to do surgery on them, you should do surgery on them. It works well, and it gets them back to normal often.
For those of us that treat a lot of kids, it's always the parents that you have to treat more than the kids. I mean, have you got any strategies for the parents that are over-enthusiastic, over-optimistic, over-realistic, and you just sometimes have to say to them, this child needs three months off, this child might not be able to play the piano, the violin, swim, and do lacrosse?
By the time they end up with me, it's usually they've got no choice. So, so that's probably a question better directed.
Especially in tennis, usually the parent is more keen than the athlete. So I have good rapport with the athlete, and I know where I'm going. But then the parent is actually organizing the tournaments. And if it's a kid that has dedicated her life or his life on tennis, they will probably not be in a normal school, and they will be self-tuition. So that's when it's more important to actually handle the parent. And again, it's education. But I'm not always successful. We agree things, but I wish we were signing contracts, because then the agreements get broken very, very easily.
I always have an approach to this, which is to work with the coaches, especially with children who get injured. And the line I always use to them is that the coaches are more interested in how you react to the injury than how good you are at playing the whole sport, because throughout your professional career, you are going to get injured, and how you react to that injury becomes very, very important. So being positive about it, but also following instructions, making sure rehab is done correctly, and that actually helps you in the long term as well. And that's the sort of line that I go through with both the parents and the child. And it seems to work sometimes it doesn't, and the parents will still push. But it really is just to make sure that they're aware that everyone around the team is trying to do the best for their child as well.
That's a great point. I echo that.
I think some of us only, especially as a physician, you only work in a club maybe once a week, twice a week, etc. But I find that certainly the physio staff at the clubs, they know the family inside out, and they know how to manage the family, far better than what certainly I would, and how to relay the messages and get the compliance up. So knowing the family, somebody in your organisation has to.
Many of the challenges come, in my experience, come outside of the sort of the well-supported, well-resourced football club environment, where maybe you've got another patient who's got pushy parents and is clearly talented at what they do, and are being pushed, and as they grow up, each year that they progress being talented, their coaches grab hold of them and crank things up, and the load just goes up out of control astronomically, and then they find out that they happen to be very good at hurdles and long jump as well as sprinting, and before they know it, they're training 7 days a week, and it is very, very difficult to control. and sometimes we don't really have a great deal of access to psychological support, but family support is absolutely critical, and I suppose all of us do a bit of that in our routine work, but very, very challenging.
I have a question for Nico. I'm now a physio, but I was a professional dancer. I went through Royal Ballet training, so I know exactly the background that you're in. Ballet does require a huge amount of flexibility. It's very difficult to develop the strength. Everybody develops at different rates. Often the most times that people get injury is because they have a limitation in one specific area, so they compensate from that. It goes all the way up the chain. That can be quite difficult to change that stiffness, for want of a better word. And do you think there's sufficient screening or realistic expectations set when people audition for these schools? Because I know when I was at Royal Ballet, you knew if you were in the top class, you had a chance, and there were another 2 classes that were taken in that really, realistically, you're kind of fostering unrealistic dreams of having a career that's very difficult to reach the top in and have a sort of financially sound future.
The vocational schools do have screening protocols, and it's good to see. What the artistic director does with the screening reports is a completely different story. And when you actually see the audition and the way that they're actually judging is a little bit irrelevant to the final product. So when you see lower school auditions, they are asking the kids to do things that are not really important. And also this talent identification is something that we know that it doesn't work. So it was really nice to see yesterday one of the genetics presentation where they said 2/3 of flexibility relies on our genes, and I actually tweeted this at the school because flexibility is an issue and it has limitations. Screening does exist, but I don't think that there is enough education for the dancer so that the dancer understands that the limitations are there. So then we have the forced turnout or the forced box splits or the overstretching. So again, we're going back to education at a very young age in order to explain how anatomy works and what the limitations are there because of who you are.
Hi, I'm Anna Broderick. I work at Central School of Ballet Physio. So I do the audition screenings it's approximately 4 to 1, about 4 to 1 final auditions. We have 3 auditions, and so, the last intake I sit in. And it's very interesting because I have to screen 120 dancers, and I get about 6 minutes per dancer. It is battering. It's a battery test which we roll out, and it's an evolution because of the notice that artistic staff will then take of that orthopaedic screen. I'm not shy to take on injuries, and if somebody is coming with a huge osteoarthritis, that's fine. We can deal with that. And it is about the talent in the studio. However, I do shy away from people who are too bendy. Because I think they are riddled with hypermobility, and that's a big thing for me because they really struggle to gain lots of strength and control of their movement. If it's localized, I'm not so wary, but if they're literally riddled with it, and also just basic biomechanics, and sometimes they take them, and it boils down probably to financial decision making of having to fill a number of places per year, which is always controversial, as you say.
Absolutely, but the problem is that we can define hypermobility and we can shy away from it, but the artistic world somehow actually attracts this, and their eyes actually go to the sway backs, and they want to see the straight line of the knee and of the toes and of everything that we wouldn't really particularly like. So it's.
And one last point: are they open at all now? Because it's all done in the academic years, and often, especially with people that have got a lot of mobility, different people develop strength at different rates. So it would seem more logical from a physical point of view to keep somebody back in their training for a year. Is there any sort of openness to keeping people back now, or do you have to?
It's a good point, but we're not there yet. What we are doing now is, I'm trying to put the data together for the school to actually change some things, but change is a very bad word in ballet. So to give you an example, last year in August, when they were putting the program together, I asked for the final year, just the final year, not to jump for 4 weeks and to give me the dancers to do jump preparation before they actually start jumping. And I did the calculations of the load, and I was decreasing the dance load, if you want, by 30 minutes a day, which is 2.5 hours a week, which is 10 hours in a month. And then I did the calculation over the 1,000 hours that they were doing over the 35 weeks, and it was 1% change. And believe me, that was the worst thing I could have suggested. The teachers, especially the upper school teachers, started swearing at me and saying, you have never trained a dancer. How do you know that this is going to work? And my answer, which I didn't say, was like, yeah, but I haven't broken a dancer yet. So.
Hi, I'm Kate Jackson, sports doctor, and I look after academy football. I was really pleased that there's an adolescent stream. And I just wanted to point out and pick up on something Richard just said, which is that what hasn't been touched on is the psychiatric causes. And I've had a young lad who was 10 and had injury from overuse, but his overuse was linked to OCD. And I've had several young girls coming through the academy with psychiatric disorders related to eating disorders. And it was just to pick up on the fact that their overuse sometimes in this age group, this is when psychiatric disorders emerge, and it's just something to keep an eye out for in this age group.
I'd completely echo that, and I think that's looking across the whole country, not just in sport, but I think childhood psychiatric conditions are coming much more to the forefront now, and how we treat them and how we manage them very early on can influence later on, so I'd completely agree with that.
Thank you. I'm Sajid Bhatt, radiologist. Question to Mr. Banks. How frequently do you see muscle tendon injuries in patients who present with groin pain? And do you have any injection treatment strategy for them? Or you?
I don't really see that kind of clientele very much. As I say, I haven't really concentrated in my talk, because as I say, acute hip injuries in adolescents, they don't usually get to me. The only problems I see with the avulsion injuries is if there's heterotopic bone formation associated with the apophysis healing, or if the apophysis heals long, particularly the anterior inferior iliac spine. So they sometimes will get a blocked flexion. Got a lovely video that sadly I couldn't show you of that. But I don't really get involved in that stuff, I'm afraid. So my sports medicine colleagues will be probably better to deal with that.
In my experience, obviously, they do get muscle and tendon injuries, but I find the avulsions just more common. It's the weak area. It's the area that usually is managed conservatively, and there's not usually complications. But yeah,
I think, and leading on to that, I'm also interested in Marcus. I always get Marcus to talk. It's always interesting. But to be controversial, I mean, if you had an adolescent with a labral injury on their hip that you proved. And you talk a lot about surgical, but non-surgical treatments, and there's a lot of talk at the moment around PRP and whether there's a use for PRP in these patients, and not putting the arthroscope in and not doing those sort of repairs.
Yeah, I mean, you don't do the operation next week. I mean, there's a period of reflection, and but the key thing is to make the diagnosis, and that's the number one thing. Say, yes, you've got a labral tear. Yes, sometimes they get better, sometimes they don't get better. The thing is that after you've looked at, I operate on this age group quite a lot. You always, particularly in the boys with CAMS, these are teenagers and they've got full thickness cartilage damage to their front of their acetabulum. So this is not just a bit of this and that. This is like irreparable damage to their joint that leads to osteoarthritis. So as I've sort of got more experience, I'm more enthusiastic about surgery because I've seen the effects of the damage of the condition, which we've really only learnt about in the last 10 years. And I've not seen, of course, I'm only seeing the group that don't get better with surgery. And again, I'm here very much from a surgical standpoint to say that, this stuff's available. But, quite a lot of them do get better. I don't know what percentage do, or it comes and goes. But the other point to make about operating on adolescents is they're clearly the most vulnerable to their anatomical abnormality, because most people present with hip dysplasia in their 20s and 30s. So these teenagers are they're coming in as teenagers. And so therefore, whatever anatomical abnormality they have, they're sensitive to it. And therefore, if you fix it early, they go back to normal, and quite often they do. It's a bit like, spotting a tiny bit of wear on the tyre and thinking, oh, is my steering right? Well, if you realign the steering, the tyre has effectively a normal life. And that's why I'm much keener on operating on this age group. Again, going back to the point that they do well with surgery, nice therapeutic environment. So it's actually a good time to operate on. They think their lives are very complicated. I can assure you their lives are very, very simple. And they can incorporate surgery into it, in a school holiday or whatever, very, very easily.
So I'm sure those debates will come in. I'm afraid we're out of time now. It's been a really great occasion, I think, and a really good discussion amongst us. I'd like to thank all our speakers and our audience as well for coming. Thank you very much.